Hello, welcome to Quick Notes, the division of the What is Medicine channel. Now this division is aimed at just going through quick, less common diseases we encounter in clinical medicine. Again, aimed at medical professionals. Right. So today the topic is tumor lysis syndrome. Now it is pretty well known. Now let's try to go through some of the less common aspects of it. Who gets tumor lysis syndrome? Typically patients with Burkitt's lymphoma or acute lymphocytic leukemia. They're the most likely culprits to get tumor lysis syndrome, or a degree of the disease. Obviously, tumor lysis syndrome is on a spectrum severity, right? So also patients who have rapid tumor growth are going to be candidates for tumor lysis syndrome. Any patient with a white blood cell count greater than 50,000, patients who have highly sensitive tumors to chemotherapy, again, high risk for tumor lysis syndrome, and any patient with pre-existing renal disease. Obviously, if you can't eliminate the target toxins, etc., you're going to be at high risk. So, what causes people to get thrown into tumor lysis syndrome? Typical insults are cytotoxic chemotherapy, cytolytic antibody therapy, again, things that break down cells rapidly. Radiation and steroids can also trigger it. So what ends up happening with when you get a patient who you're suspicious of tumor lysis syndrome? Now, cells are rapidly lysing. So along with that, intracellular now becomes extracellular, right? So we have rapidly increasing potassium and phosphorus levels, along with rapidly increasing uric acid levels. Uric acid levels go up as the DNA is released, DNA gets broken down through the purine pathways, final product being uric acid in the body. Now your calcium is going to begin to drop. Calcium drop is actually secondary to the high phosphorus. You end up having calcium phosphate crystals, which then deposit in the urine, give you kidney stones. And you remember calcium phosphate kidney stones as well as uric acid kidney stones, kind of like gout, painting a gout picture. So when would you be concerned of a patient having tumor lysis syndrome? So there's typical symptoms: nausea, vomiting, diarrhea, which are common with any form of chemotherapy. Additional symptoms that you may see are kind of related to the electrolyte abnormalities. So you have potassium, elevated potassium, cardiac arrhythmias. You can have hypocalcemia leading to seizures. Uric acid levels can be elevated, leading to a gout-like image clinically, right? Now, the diagnosis, specific diagnostic criteria is according to the Cairo-Bishop scoring system. Cairo-Bishop scoring system either follows one of two pathways. The laboratory analysis pathway requires greater than or 2 lab values of these 4 outside of 25% or greater outside of the normal reference range. Now, there's a clinical diagnostic pathway. To diagnose it clinically, you can have a patient with either seizures, arrhythmia, or creatinine of greater than 1.5. Now, those are clinically diagnostic criteria for tumor lysis syndrome. Now, keep in mind that within these criteria, patients, this disease is a spectrum, so you may have early form, may have later forms. So just something to keep in the back of your head if you have a patient with any of these known risk factors. Now, as far as treatment, both when you have the disease and prophylactic treatment, there's kind of criteria predefined for low risk, medium risk, and high risk. Now, that's based on the risk criteria as well as the specific tumor types and subtypes, therapies given, etc. All that can be found up to date through their website. They have charts, tables, etc. In general, when you have someone with tumor lysis syndrome, mainstay treatment, IV fluids, give them lots of fluids to dilute everything out, flush it out. Now, keep in mind, a lot of these patients have cardiac diseases as well, so you have to work within the limits of their cardiac abilities. Lasix can help you diurese as well, removing the potassium, if anything else, helping you get rid of that potassium, right? Now, you want to fix electrolyte abnormalities. Obviously, you don't want your patient sitting there with a potassium of 8 and calcium of 2, so replace as you need to keep their electrolyte abnormalities as close to normal as possible. And now the big golden thing is that allopurinol and rubricase, the medications used to reduce the uric acid crystals, right? So commonly, allopurinol is used for uric acid in the form of preventing gout. This has been going on for many years now. The issue with allopurinol, specifically in tumor lysis syndrome, is that allopurinol diverts the uric acid down a different pathway, forming xanthine. And xanthine can actually form crystals within the kidneys as well. Now, we don't test for xanthine levels, we don't find crystals in the urine, but if someone is at high risk for tumor lysis syndrome, typically they'll put them on rubricase for that indication alone. The rubricases breakdown products are water soluble and don't form crystals within the kidneys. So something to keep in mind. Typically low risk patients for TLS do still get put on allopurinol. Again, there's cost is a factor, side effects, etc. But just something to keep in the back of your head. Someone's rapidly going into tumor lysis syndrome. You have some of the cardiovascular criteria. Maybe better to shoot with the big guns of your case. Again, this was tumor lysis syndrome. Kind of a brief 5 minutes or less was the goal. We'll see how long it comes out in the long run. Now, thanks for watching. Any suggestions, future topics, throw them in the comments. Thank you.
Use the